Hello, everyone. Welcome and thank you for joining the 28th webinar in our Pandemics and Society series. Today's webinar topic is the global fight for vaccine equity, a conversation with Seth Berkley. I'll now pass it to our moderator, Jennifer Nuzzo, the director of the Pandemic Center and professor of epidemiology at the Brown University School of Public Health.
Hello, everyone. Welcome to our discussion today. So of all the products that science has developed to protect and promote public health, it's hard to point to tools that have had more of a profoundly positive contribution than vaccines. In a 2024 study published in The Lancet, the World Health Organization estimates that the global immunization efforts have saved at least 154 million lives in the last 50 years alone. Now, if we also add to that the contributions of the global smallpox eradication program, the true life savings is probably closer to 500 million, possibly more. This is a truly extraordinary achievement. But we know that not everyone is fortunate enough to be able to access these life-saving tools. For many, vaccines are too expensive or too hard to access. In 2000, the world came together to launch Gavi, the Vaccine Alliance, and for the purpose of working to increase the world's access to vaccines, particularly in the world's poorest countries. Since then, the Alliance has worked to protect hundreds of millions of people against vaccine-preventable diseases, a remarkable impact. But the fight to ensure that people everywhere have access to life-saving vaccines is far from over. And recent efforts to attack and defund public health agencies and organizations, including Gavi, may erode much of the incredible progress that has been made to date. So where does that leave us? Where does that leave us for vaccines, for access, and for vaccine equity? And that's what we're going to discuss today. And I am very pleased to have as my guest Dr. Seth Berkley, who is Senior Advisor here at the Pandemic Center. Dr. Berkley is not just a global health expert, but a pioneer in vaccine access. He's responsible for the provision of vaccines to more than 50% of the world's children. Dr. Berkley previously served as CEO of Gavi, the Vaccine Alliance, from 2011 to 2023. His leadership was instrumental in co-founding and spearheading COVAX, an initiative that enabled the distribution of more than 2 billion COVID-19 vaccine doses to 146 nations. Another very important aspect of Dr. Berkley's bio, which I have to point out, is that he's also a proud Brown alum, and we are very happy to welcome to our discussion today. In just a few days, on October 28th, in fact, he'll release his new book, Fair Doses, an insider's story of the pandemic and the global fight for vaccine equity. It's a really important contribution to help us understand the overall fight to promote and provide vaccines. And so we have a lot to talk about. So welcome, Seth. Let's dive in. First of all, maybe we'll just start with the beginning. Talk to us about your life since Brown, or more specifically, how did you get into this work on vaccines? What did that kind of career trajectory look like for you?
Well, first of all, thanks for having me, Jen, and great to see you and great to be back at Brown having this conversation. I loved science as a kid, and when I was trying to figure out where to go with science, I ended up in medicine thinking that I could make a difference. And I loved clinical medicine, really loved it. But I began to realize that if you really wanted to have a big effect, you really needed to be thinking about population health and then public health. And so I went through the normal thing after I left Brown Medical School and did an internal medicine residency. And the academics at the place I trained, said, "Oh, if you're interested in infectious diseases, you should do an academic infectious disease effort." But I actually decided instead to go to CDC and join special pathogens there. And the reason I did that was because I wanted to get training in epidemiology. And I also began to get interested and do some work internationally during that period. And that's really what exposed me to international vaccines and is really the way that, one could arguably say you can have some of the biggest effects in the world. That study you talked about in the introduction, the 154 million, doses, the estimates are that about 40% of the effects on child mortality came from vaccines. And so this is really a profound thing. And, the challenge is not only to get them out, but also to develop vaccines for the most important diseases. And these are the things I've kind of, dedicated my career to.
So thank you. And just maybe for people who don't really understand, I mean, I think we're at a point where a lot of us take vaccines and the ability to get vaccinated for granted. Maybe you could talk a little bit about perhaps what that may not have always been the case, certainly may not still be the case, and then this larger question of vaccine equity for people who don't understand what that term means or why it's important. Could you just talk a little bit about the kind of the fight to promote access and availability?
Yeah, so let me start with the history of this, and it's quite interesting, and it's something that I talk a lot about in the book because I think it's important for people to understand it. So in 1974, WHO launched the expanded program on immunization. At the time, less than 5% of people in the world received even a single dose of vaccine. So it wasn't they received all the doses, not even a single dose. And today, vaccines are the most widely distributed health intervention in the world, with about 90% of families of kids in the world getting at least one dose through the routine vaccine program. So in that sense, there's more equity with this than there are with other health issues. But of course, if you look at that last 10%, the so-called zero-dose children's families, that's about half of the under 5 child mortality exist in that 10% of kids, and about 2/3 of them live below the poverty line. So this is a really great way, if you kind of try to get as close as you can to 100% coverage, to be able to solve the equity problem and the child mortality problem. So that's really what has to happen. Of course, it's about having vaccines available, but it's also about trying to have delivery systems in place and trying to have, the whole health system and supply chain and all of that needs to be there. But for, pandemics, it's also important because these communities, if you don't get vaccines, you're not getting anything. So these are, kind of spots that are outside of our normal surveillance systems. And once you put the system in place, they have some access to a health worker. And that obviously can also be an early warning system if there are outbreaks. So from my perspective, equity is trying to get vaccines to everybody who's willing to take them. And that's important because obviously vaccines are voluntary. And, there is a whole problem with vaccine hesitancy, I'm sure we will talk about, but the point here is that sometimes the wealthy were having access to vaccines, and you can arguably say that it's actually the poor who have less access to health care who, might get even more benefit from those vaccines. So that's really what we were trying to equilibrate.
And maybe just to drill down a little bit more, because we're at a point in our politics where the word equity is, triggering some criticisms. And
I was told to take it off the cover of my book because they said equity is a lightning rod word and you shouldn't do it. And I thought about it and I said, no, this is important. It's vaccine equity. It's critical.
So there's clearly a moral issue around equity, but maybe if we could put that aside for a second, though I think that is quite an important issue, but maybe just wearing an epidemiologist's hat, talk a little bit about why equity for people who maybe think that it's about, that there's, putting aside the larger political argument, just talk about the epidemiologic argument for vaccine equity.
Yeah, I mean, there's two arguments, and it depends upon the type of vaccine. So there are vaccines that just protect a person, like tetanus. If you have a tetanus vaccine, you will not get tetanus. But tetanus is not something you can transmit to somebody else. So that's about personal protection, and equity there is about having people access to not getting this terrible disease and not bankrupting health systems. But the other side of it are diseases that are infectious, like measles, which is the most infectious of all diseases. And there, what's critical is trying to get coverage as high as possible to have something we called herd immunity. And what that means is that not everybody, even if you vaccinate them, will get a take from the vaccine. Or you may have people who, for example, people who have been treated with cancer or have immune problems who will not be able to be vaccinated. And so to protect those people, what you want is to have enough immunity in the population so that if the disease, somebody gets exposed, it'll die out because the rest of the herd is immune. And that's a critical concept in vaccines, and one where if we start seeing a dropping of vaccine coverage, we'll start seeing spread of infections, and they can be, quite shocking. And of course, right now in the US, we're in the midst of a big spread of measles. In the US, we eliminated measles in 2000, and now we're seeing it spread all over the place. And that's obviously due to having low coverage because the vaccine actually is pretty effective.
Thank you. Yeah, I think we have to make very clear all the multiple benefits of these approaches. Appreciate your thoughts on that. Prior to returning to us here at Brown and senior advisor at the Pandemic Center, you were CEO of Gavi, and I want to talk about that. But I wanted to first start with an organization that maybe people might be somewhat less familiar with, IAVI, which is an organization that you founded. You were also named in 2009 as Person of the Year, one of the 100 People of the Year, or most influential people in the world, for your efforts with IAVI. Can you talk to us about IAVI, what it does, what it is, why you founded it, and what your experiences were like as part of IAVI?
Yeah, no, thanks for asking, Jennifer. And it's interesting because I was at the Rockefeller Foundation. I actually lived in Uganda for a couple of years, where I was the Ministry of Health epidemiologist and worked on AIDS and did the first national sero survey to find out what the prevalence was. So that was a part of what made me obsess about AIDS, because I realized how severe it was in Africa and what it was going to likely cause in the future if we didn't get it under control. And when I was at Rockefeller, a number of people approached me and said, the AIDS vaccine effort is not going as well as it should be. And in particular, it's not being directed at the places that have the biggest spread and have the widest variety of strains of the virus. And that was Africa. And so initially I did some investigations, and it turned out to be true. So we very boldly initiated a new effort whose goal was to focus on trying to move AIDS vaccines forward, to also advocate for more spending and more attention, but also to do and empower clinical research in the parts of the world where it was spreading the most. And we ended up creating a whole range of vaccines, doing, I think, the 24 different clinical trials. Many of the countries had never done a trial before, and building capacity and building laboratories. And it really was a very rewarding effort. Of course, today you can say it didn't work because we still don't have an AIDS vaccine. But of course, the science is very difficult. And in fact, we're seeing slow progress, although that has now been shut down by some of the cuts that were done to USAID and NIH and others, which is really unfortunate because I think we still need an AIDS vaccine. But that was an important lesson for me, because that was about public-private partnerships and how to engage industry, how to engage developing countries, how to build political support. I raised about $1 billion as part of that effort, and it is still going today, and actually has done work on besides the work on AIDS, has done work on Marburg vaccines, Ebola Sudan, other important vaccines that are critical for outbreaks.
Thank you for reflecting on that, because I think the COVID-19 pandemic has perhaps left some with the impression that, well, maybe vaccines aren't so hard to develop, and perhaps we have gotten a little bit picky about the vaccines that we ultimately wind up being able to produce. I think kind of reflecting on just how hard it is and how the science doesn't always work in your favor. It could take a really long time, I think is quite an important reminder for people who haven't seen that long journey and fight.
Well, let me just say before you move on, two things
please.
about that. One is I discuss in the book the kind of average time, or the average success rate of vaccines is around 7%. So, and people will say, well, that wasn't the experience in COVID. And of course, the reason it wasn't the experience was we had two previous coronavirus outbreaks. We had SARS and we had MERS. And for both of those, there was an effort to create vaccines. And And although neither of those got licensed vaccines because people stopped working on them when they no longer were public health problems, people solved the science problem. So when all of a sudden, we discovered it, in Wuhan, this coronavirus infection. People knew how to make the vaccine antigen that was necessary, knew what the immune response would likely need to be, and so that's why it was so successful. But HIV, of course, is extremely difficult, but there are other agents that may be difficult. So we can't take it for granted that we will just be able to, in 100 days, the CEPI goal, or 327 days, what we actually did this time, that'll happen again.
Yeah, I mean, for people may not realize, the first coronavirus epidemic, SARS, was in 2003. So we were really benefiting from nearly 20 years worth of scientific research, and also just a pathogen that was favorable in terms of that research, which, HIV has been a very challenging virus. I think it really underscores the importance of preparedness and these long-term investments in basic science, and then ultimately more applied science, et cetera. So yeah, it's quite a journey, and I think people just have forgotten about how truly remarkable it was that we were able to get multiple safe and effective vaccines in the pandemic, but not without a lot of effort over decades. I wanted to turn a little bit, because we'll get to a discussion of vaccines during the pandemic, but maybe we could start first with talking about Gavi. One thing I found is maybe people don't really understand what Gavi is, and I think because particularly it's been in the news lately over funding fights, I think it's important to talk about sort of what Gavi was founded to do and what its accomplishments are. Could you speak a bit about that?
Sure. So when that effort I talked about of going from 5% up to 90%, it really got stuck in the 1990s, and it got politicized, and there was a new organization, the Children's Vaccine Initiative, that was going to move in and try to revitalize it, and it really didn't work. And so Gavi was a new experiment. It had a person who was behind it, who at the time was the richest man in the world, Bill Gates. He asked the question, why are we not getting vaccines out? He read the World Development Report, which the bank had put out, and after reading that, he said, well, clearly we should do this, and he put a lot of money on the table. But it was an experiment because the previous thing had failed, and the idea was, how do we pick the vaccines that are coming out, that science is moving forward, and try to get them engaged in the developing world. And it's been a remarkable success. I don't say that because I ran it for more than half of its life, but it's actually vaccinated 1.2 billion additional children. And it's launched about 700 vaccines in terms of doing this, and has increased the coverage, and is responsible for reducing vaccine preventable deaths by about 70%. So this has really been an incredibly successful effort. It's an innovative effort in that it works using market mechanisms and a lot of innovative financing mechanisms, working with companies, working with public sector, working with countries to try to drive this forward and to build the systems in addition to having those vaccines purchased. And during this time, the two largest killer children, diarrhea, pneumonia, vaccines for those, but also 2 cancer vaccines for liver cancer and for cervical cancer, and now for parasitic diseases like malaria, and recently, also for a range of epidemic diseases. So keeping the global stockpiles for yellow fever, for Ebola, for meningitis, for cholera, for Mpox now. And so it has really, been a successful effort. But the last thing I'd say about it isn't just an organization, it's an alliance. It brings together a number of partners. And the advantage of that is you don't have to, create new things and create competitions, but rather work together synergistically, which was very helpful later on when we had to step up for a pandemic.
So the impacts of Gavi in terms of promoting global child survival are really extraordinary. But, if we think about its role during the pandemic, I mean, it's quite stunning that the COVID-19 pandemic was one of the largest adult immunization programs in modern history. I mean, certainly since smallpox eradication. I don't know. Inform me if I'm missing one. But can you talk a little bit about the kind of the challenges of getting into adult immunizations and just what the experience of talk to me about COVID-19 and your role at Gavi. Quite a challenging situation, despite the scientific advances of these vaccines. Now we have to figure out how to get them to people and get them to people in a world where a lot of immunization efforts are focused on kids and not necessarily adults.
Yeah, I mean that's absolutely right, and it was the largest campaign ever in history in terms of where it was and the reach of it, and it actually was the most equitable rollout, although it had all kinds of problems and there was a lot of inequity. So we'll go through that. I mean, the big surprise to me at the beginning was there was no plan in place. There was some plans that had been worked out a little bit for influenza because that was what everybody thought was going to be the next big pandemic after 1918, after the avian flu, pandemic. And so that's kind of what people had prepared for. And if you looked at what happened in 2009, high income countries bought up all of the doses of the vaccine that was ultimately made. And so it really wasn't shared until after the pandemic. Then there wasn't so much of a need for it, and some doses got to the developing world. So we decided, we didn't know if this was the big one or if it was just a dress rehearsal, but we decided to try to do what we could to dampen that. And so we set up the concept for COVAX right at the beginning, but we had no money, we had no staff, and we had no mandate. And so the challenge was then to try to build that. I joined forces with Richard Hatchett, who was the CEO of the Coalition for Epidemic Preparedness and Innovation, CEPI, and of course with the alliance partners, with others, and we began to fundraise and to begin to try to work to put orders in place, to do technology transfers, build systems, get countries ready, et cetera, et cetera. We had an amazing outpouring. 193 countries joined COVAX. And, the only ones that weren't there were the US, Russia, a couple of other small countries. So it was really amazing to see that outpouring. And, the goal was to try to put some equity in place. Now, we weren't naive. We knew that the normal thing that's going to happen is vaccine nationalism. And, it is, and in a sense, that has to be because every country leader should want to, and their job is to get whatever countermeasures are available for their population. The question wasn't that. The question was, do you vaccinate every single person in your country, or do you vaccinate the high risk groups and then try to vaccinate high risk groups in other places? So, in a pandemic, what you'd like to do is make sure that, for example, healthcare workers around the world have access so that they can then take care of people and be involved. That's really what we were trying to do. And we had all kinds of problems of export bans and bad behavior of political leaders and bad behavior of company leaders. We did our best to try to overcome those, during it. And a lot of the book talks about those stories. In detail and what happened. At the end, 57% of people in the half of the world, the 92 poorest countries, received a primary dose of COVID vaccine primary dosage, because one or two doses depending on the vaccine, and that compared to about 67% globally. So we didn't get to equity, but not that far off. And of course, there were more high-risk people in the higher income countries. But of course, that was delayed, and there were a lot of countries, the very, very poorest countries, had very low coverage right at the beginning, less than 1% in 2021. So there are a lot of lessons there on what we need to do better in the future.
And maybe just to kind of refresh memories a bit more, which was, in the 2009 flu pandemic, there was a H1N1 swine flu. There were a lot. So central premise, there are only a few companies in the world that make vaccines. Certainly when we're talking about flu vaccines in particular, they don't make enough for the world. And so the way that countries responded to the 2009 pandemic was largely to promise to donate vaccines that they didn't need to other countries. And those promises perhaps were not enough, but still what was ultimately delivered was less than what was promised and arrived later than what was ideal or even useful. So that, I think, prompted an understanding that we need to figure out in the next pandemic what to do. Here we have COVID, and then still a situation where there's not enough being made initially for what the global need would be. And so there are questions about making more. There's questions about getting what is made to the places, and then there's questions about who should get it first. Can you just say a little bit more? Because I don't think people truly who haven't been involved in the details can really understand why it was so challenging to get vaccines to the highest risk, highest need places.
So first of all, in a sense, they're a little different. So flu is a vaccine that is produced, that is sold, but it's not used in most poor developing countries. And that's an important point. So, and I tried at Gavi to get people interested in that for the reason of flu kills a lot of people in so-called peacetime. But obviously, if we had another bad pandemic, if there's not production of vaccine and experience with vaccine, it's hard to deliver it. So the way people dealt with flu was they basically put in place an expanded system of producing flu for seasonal flu, with the idea being that if you had a pandemic flu, then you would shift the production to that pandemic flu. And it would be, it's a different strain, but it would be the same type of production. So that's how you would deal with that. But it wouldn't deal with developing countries because you couldn't get to those numbers without an expansion. Instead, we ended up with a coronavirus infection. So we had no experience at taking that to scale. Nobody was producing it. There was no licensed products. And lo and behold, I would argue Donald Trump, one of his successes was putting together Operation Warp Speed, where the US government said, we're opening our treasury up. They spent, I think, around $10 billion to fund a bunch of vaccines, a number of which were these new, not yet licensed mRNA vaccines. Now, that makes it even more complicated because although those are vaccines that had some research done, which is why they were able to be moving so quickly, they required ultra cold chain at minus 70 degrees. They required different syringes and a completely different production mechanism. So we had to scale that up and then also scale up regular vaccines. And the amazing thing is, when I was asked how long it would take, I said the fastest vaccine to that point was 4 years. Maybe we can do it in 2 to 3 years. It was 327 days because of mRNA. But the second part of that is how many doses could we produce in the first year? And remember, we have to continue to make the vaccines we need to protect against existing disease. If you don't, you're going to end up big outbreaks of those diseases, could kill more people than the pandemic. So we thought maybe a couple of billion extra doses. It turns out the world produced 11 billion doses of COVID vaccines in that first year. So that's enough to vaccinate everybody in the world at the time. But the challenge was that countries, rightfully were not buying one vaccine. They were buying 2, 3, 4 vaccines because they didn't know which was going to work. And so what you had is all of the supplies again being, in high income countries. And that's why we ended up in a situation where countries, they waited until they figured out they didn't need them, but then there was very little shelf life, and then they were desperately trying to give them to us or transfer them, and there were legal issues associated with that. So we had to build a whole system for dose donations and build in timelines and do other things to make that also work. But it is important. Today, there is enough capacity to produce vaccines, but there was not good distribution of capacity. And so there's a movement also to expand the distribution of production facilities. Africa, for example, only has one pre-qualified production facility. So, they have a large percentage of the population, but don't produce very many vaccines there, and there's a big movement to try to change that.
I guess maybe just looking forward, we're going to have another pandemic. We're going to have another pandemic. They happen regularly throughout history. In the 1900s, we had 3 influenza pandemics. We think if you look back on history, there's some evidence we may have had some coronavirus pandemics before. We're going to have more pandemics. We don't know when the next one's going to be. We don't know what pathogen it's going to be, though we have a suspects list. But we're going to have another one, and we know that vaccines are the game changers in terms of protecting people against severe illness and also just allowing society to continue to function. I guess maybe looking back on all of the experiences, like what's the single biggest lesson for you that you think we need to carry forward in getting ready for the next one? Maybe it doesn't have to be one lesson, but what have we learned so far about how best to get ready for future pandemics? Recognizing that there are some market challenges for making things that we don't know what it's going to be and when we're going to need it. Like, if you had to start developing the plan for the country or for the world right now, what would you be looking at?
Well, first of all, there's some prerequisites. So one is you got to keep the science going. And, unfortunately, right now, we're at a moment where, we're destroying a lot of the scientific expertise that exists. But why is that important? It's, as we said, the reason we could do COVID vaccines quickly is because we had spent the research to try to understand how to make coronavirus vaccines. And the same thing with flu. Why can we move to do flu vaccines? It's because we've done research. And by the way, we need better flu vaccines. So these are all areas that we want to continue to do as part of the background, because we don't know, as you said, what the next one's going to be. It could be disease X of an unknown agent. It could be an existing agent, but a different strain. And so we need to be prepared for all of that. So that's one lesson. A second lesson is the systems for it. And that's important. The best way to build up a system to do vaccination is to strengthen the existing systems in peacetime. And the way you do that is you reach those 0 dose, you try to build the system out to the last mile. That has the advantage of helping to be able to identify infections, but it will be that same system. And by the way, those health workers, they're the heroes. They delivered 3 times the number of vaccines that they had ever delivered before, and they kept delivering the routine vaccines as well. It dropped a little bit, but I mean, it's amazing what they were able to do at great personal cost to them. So those are some, broader lessons. But then we began to build a whole new system. We built indemnification and liability so that companies would allow these vaccines to roll out. No fault compensation. We set up, ultra cold chain, doing all these things. And the challenge is not to forget how to do that, because we had to learn how to do that. But I would say the single most important thing that we have to do is we have to have 0-day financing in place. Now, why is that important? So, as I said at the beginning, we had no money, we had no people. And so all of a sudden, I'm trying to raise money and I'm trying to take on all the risk. And I got a board who's saying you can't use the money that is going to vaccinate children for, otherwise killer diseases. So, you're starting, and companies all know that we're good at fundraising, but that's not enough to have them interested. So what we ultimately created was a vaccine fund that had $500 million in it, and had then some loan agreements from the DFC, the Development Finance Corporation, and the European Investment Bank to bring it to about $2 billion. And the idea was, on day one, we can begin to prepare countries, prepare the systems, and we can begin to put orders in place and begin to do technology transfer preparation. And, it shouldn't be the total amount, because, donors are going to want to kick the tires and do all of that, but there needs to be enough to start right at 0. And that would change a lot going forward. So those are, there's a lot more lessons in the book in terms of what we learned, but keeping the systems warm that we have and having the financing available right away are critical issues. And then lastly, I think, the pandemic accord tried to make some adjustments and do some things. Of course, that hasn't been passed yet in terms of as a final treaty. We don't know if we'll get there given the situation right now. But trying to tackle some of these other complicated issues like vaccine hesitancy and fairness in this, and having companies supplying developing countries at the same time as high income. These are all challenges that are out there.
You mentioned funding, and I want to talk to that. I just want to say for participants who would like to ask a question, please feel free to use the Q&A box to pose a question, and we'll try to get to them. But I'm going to keep going, which is to talk about funding. It is estimate. U.S. support for global health funding is declining quite considerably. There's some estimates that may decline by 67%. I think there's a lot of question, but nonetheless, we're seeing the shuttering of entire agencies devoted to global health. There's also expectation that other countries may follow. Secretary Kennedy, HHS Secretary Kennedy, not only signaled an intention to reduce U.S. support for Gavi, but also spread some really vicious statements about Gavi and what it does. What are your worries? I mean, aside from this is obviously not good, but where are we with respect to this? What could this mean for the world's children, but also for the United States? I mean, what are you thinking about all of this?
Well, first of all, I'm worried about all the things you just mentioned, and I can see from your facial expressions that so are you. But first of all, I mean, it's important. There are two reasons. You already mentioned this. There's a humanitarian reason to vaccinate. It's the right thing to do. But there also is a self-protection mechanism. So, for example, we talked about measles already. Measles was eliminated in the United States. To get outbreaks, you have to have measles reintroduced. If you have a small number of cases in the world, it's harder to do that than if it's running rampant around the world. And that's the same with pertussis or diphtheria or any of these other diseases. So there is a self-interest in having disease controlled around the world, which would help us in controlling what's happening. And by the way, it's really expensive. For example, there are still 2 countries that have wild-type polio in it. When wild-type polio was introduced in a Hasidic community in New York, you had to do a massive vaccine campaign, multiple rounds of it, and surveillance step up areas. It cost a lot of money. So it is also cost effective to be out there and providing it. And you're absolutely right that right now, the problem is that not only did the U.S. pull out completely from Gavi, it wasn't a reduction. They reneged on their commitment. And I can explain what their logic was, which makes no sense. But they've also pulled out of, for example, the WHO, which plays an important role globally, and have shut down things like the CDC Global Health Program, which was also a critical role. And then you see other countries now also cutting back for different reasons. So there's been a real push to increase defense spending. And, because of all the uncertainty and will the U.S. continue to provide support for others? And so with that increase in defense spending, people have pulled back their development assistance. We see the UK and we see France and other countries, Germany, they're all, pulling back on that. So it is going to have a dramatic effect. People are going to die. Large numbers of people are going to die because of this, but also it's going to have an effect on pandemic preparedness and outbreaks in the rest of the world, but also in the U.S. going forward.
Can you just comment, you said about, and this is a leading question here, but we're reducing investments in these programs or pulling out entirely and possibly looking at increasing defense spending. I mean, to me, that seems like we are simultaneously eroding our defenses as well as trying to spend more,
Yeah, but that's, I think, one of the problems. I mean, I did a TED talk a few years ago, and I kind of used the analogy of, here's the U.S. We have enough nukes to blow the world up, for in airplanes. But if those don't work, we also have, enough in ICBMs. But if that doesn't work, we have nuclear submarines that are, under the sea at all times. And the reason we're willing to pay for that system is because people feel one needs to be prepared. Now, let me just give a statistic that is, people may not believe this, but it's actually true. If you look at military deaths of Americans, so in combat, from the Civil War till today, less Americans have died in all of those conflicts put together, World War I, World War II, Vietnam, North Korea, et cetera, than died in the COVID pandemic. So you have this security issue, which is about a natural infection killing more people, $12 trillion of disruption across the entire world. But we also, and don't count this in, is we have a risk of an intentional bioterrorism attack. And of course, I would argue that we are way overdue for that, given AI, given, synthetic biology, given where we are. And so, given that risk, to spend $1 trillion on so-called security, military security, but to leave out the global health side seems very, very foolish indeed. And so one of the arguments I think that's really important, and by the way, the military is understanding this now more and more, is that you can't have global security without having biosecurity as well. And how we make sure that we keep those both in mind, it's going to be really important. Obviously, it may cost more to build aircraft carriers and nuclear submarines, et cetera, than it costs to do biomedical research. But the point is, you can't cut one out and expect you have security on the other side.
Yeah, and I think, just looking at the US military and continuing to invest in vaccine research and particularly mRNA vaccine research, I think signals how they believe that having vaccines for future disease threats is part of our national security, enterprise. So, yeah. I'm going to turn to the questions that we have in the box here. The first one is a very important one. I mean, they're all important questions, but the first one is about public health communication and vaccine hesitancy. What can we do? What can we do to improve it?
Yeah, I mean, the challenge is just to say historically, from the time the first smallpox vaccine was done, there was a wood carving with people having horns coming out of people's heads because it was from a cow, and they said, you're going to grow cow's horns out of you if you take this vaccine. So there's always been misinformation, and that has led to hesitancy and concern. But that usually was able to be dealt with experts, with science, with working and having trusted leaders, whether they be religious leaders or community leaders. What's changed now is we have, misinformation and now disinformation spreading at the speed of light with the social media and with the internet. We have Russian bots, Chinese bots, North Korean bots putting disinformation out to try to destabilize societies. But on top of that, we now have political leaders putting out misinformation. And this is something that is really new because, not that there haven't been in the past, but the way it's happening now is it's become highly politicized. And so you have, if you look at the US, more people died of COVID who were Republicans than Democrats, not because there's any inherent difference in their susceptibility, but less people got vaccinated during the height of the pandemic in Republican communities than Democratic communities because of the information difference that people were receiving. So I think for right now, we've got to do a better job of having information come out and deal with expert information. I know it's one of the reasons that the Pandemic Center puts out its own information source, but as we now pull away from trusted efforts and CDC and is mortally wounded, and even the press that does this type of stuff is pulling back. So I think this is really a challenge going forward.
Maybe I'll just add my own little editorial comment, which is that I think we as a field maybe need to move away from calling it vaccine hesitancy, which sort of blames somebody for not wanting it, and a little bit more take on the onus ourselves about stimulating demand. Because we have to build an infrastructure that not only provides people with the information they need, but also overcomes mis and disinformation, and works with people to understand why these tools are in their best interest. And I just mentioned that because if we don't build that infrastructure, it just is a add-on and afterthought. And I think for me, the pandemic, I think illustrated that, where we had this tremendous success in developing new vaccines, but comparably less effort, less spending, less infrastructure in those kind of last mile issues, stimulating demand, overcoming hesitancy, et cetera. So,
But Jennifer, I mean, I will just to say, I think it's really hard right now because when you have,
absolutely.
the American Committee for Immunization practices made up of known anti-vaccine people, and then you end up with states saying, well, we're going to have to put our own, recommendations out, and professional societies and others. And I understand their instinct to do that, but it creates even more confusion among the average person
Right.
on what's right to do here. And this is, I understand. I'm a parent. You're a parent. Of course, we want the best for our children, and and people get scared about giving things or worrying about side effects, et cetera. And they need to have reliable information, not these conspiracy theories that these days. I mean, it's unbelievable what you can watch on the internet in terms of what people are saying. So, I think it's more complicated these days.
I completely agree with you. It is much, much harder. And a lot of different efforts, I think, are trying to overcome this, but it's not the same as having a centralized place for trusted evidence-based information. It's really unfortunate. Going to the next question. There's a question about cold chain infrastructure. It says you mentioned how LMICs built up cold chain thanks to COVID vaccine campaigns. Were they able to maintain this after the pandemic cooled off? Or did it create knock-on benefits for storing other vaccines and medications? And does cold chain remain an investment target, any countries in particular?
Yeah, that's a great question. And it's interesting that we were lucky on one issue, which is Gavi had started a campaign a couple of years before the pandemic to modernize cold chain and really get it out. And what do I mean by that? We used to use propane fridges, and they were awful, and they were energy inefficient, and they broke down all the time. And we began to shift to solar fridges and fridges that stayed cold even if the electricity went off for a period. And so we had put in place about 65,000 new cold chain points around the world before the pandemic hit. So when the pandemic hit, we understood both the distribution of cold chain, and what we really had to supplement was the volumes that were going to be coming. To your point, you said before about vaccinating, healthcare workers, the elderly, people with comorbidities, much larger numbers, big campaigns. So we needed bigger walk-in, storage areas, et cetera, et cetera. And that happened. The really hard part, though, was when we shifted to mRNA, which required these -70, and virtually, very few developing countries had a lot of that. And they may have had one small cold chain point for people used to use it for artificial insemination of bulls. That was like one usage that was there, but not large quantities. And so we had to put that together. And, that's maybe useful for research in the future, or maybe if, we have vaccines that require it again. But whether those will stay as useful, I don't know. But the whole system has gotten stronger and better as a result of this. And it's also an amazing opportunity now to use digital technology to both track the supply chain, to track the quality of those cold chain, to see if they're beginning to vary in temperature that could suggest they're going to fail, and get maintenance done ahead of time, et cetera, et cetera. So a lot of work is now being done follow on to be able to do that. So this may sound like, kind of nerdy logistical stuff, but it's pretty important in terms of being able to deliver these types of massive volume campaigns.
Okay, next question is, how can global partnerships such as Gavi, partnerships between national regulatory agencies and vaccine organizations, help mitigate the barrier of weak regulatory systems in low and middle income countries?
That's a great question. So there is a movement to upgrade regulatory systems around the world, and I think that's a really important movement. And by the way, academic institutions, and I know Wilmot is on this, and we've had a conversation in the past about trying to strengthen academic institutions to have more people with training in regulatory science and training in biomedical engineering and, other issues which are going to be important. But in the interim, what we also need is to have a global system because not every country will have the capacity for every different type of vaccine. So it is a national decision. There are regional groups like, the EMA, the European Medicines Agency. They can give a ruling for the 28 member states. And now there is an effort, there is an African regulatory agency that's just been established, and it's got a leader now, and the idea will be also to try to create a regional effort for doing that. And that helps because if you can get one agency to look at it, and then you can move really quickly afterwards. But this is a long-term project of building that capacity, and it's going to be critical. If you want to have vaccine manufacturing, you have to have really strong regulatory and quality assurance, quality control, because these are living things. It's not like a chemical composition. And so one needs to build up a whole bench strength of those people. And that's where academic institutions, need to get involved in terms of doing that type of training.
Great. Okay, next question. We talked about this a little bit, but I think trying to drill down. It says, in response to recent federal actions undermining the CDC. So it's a long question. I'm going to paraphrase. It's referring to these state compacts that are forming now in response to the possibility of not getting evidence-based guidance from ACIP or CDC, FDA. Basically, it's asking, like, what do you think of this development? And for U.S. vaccine implementation specifically, less of a global lens, do you think more states should follow suit?
Yeah, I mean, I'm sorry that it comes to this. I mean, as you said, Jennifer, it's much better to have one centralized authority, and then there's no confusion. But that authority has to be science-driven and has to be transparent about what it's doing. And if you're not doing those things, you're going to lose confidence. And I think the next thing to do is go to the states. Now, what you really don't want are 50 different state responses, because that's going to also create confusion. So the more you can consolidate those, and maybe it ultimately will be, having, the American Academy of Pediatrics or Infectious Disease Society or America or many other groups like that can bring recommendations forward. The other thing that's hard is there used to be a coordinated response globally. So something like influenza, you need the Southern Hemisphere data to decide what to do in the Northern Hemisphere for the next season. WHO had a process that they tried to work across countries, but as we're not dealing with WHO now. And so how do we create consensus on these types of issues? And when the next pandemic occurs, we're going to need people to have that information flowed out, and we're going to need to make sure that that information is verified and people are comfortable with, with what they learn. And so trust becomes such an important part of all of this.
Yeah, and I think one of the things I worry about, I have a lot of worries. I mean, I think this is necessary, but not sufficient. I think it was probably always necessary. I think there are some operational advantages to states working together in this way. But yeah, the absence of a nationally coordinating body it means the nation's not prepared. It means only some parts are prepared in some ways. But it creates tremendous amount of chaos and confusion for clinical providers who now have to work even harder to stay up to date as to the recommendations. It creates chaos for the providers like the pharmacies who are national often and now have to kind of have region by region approaches in terms of scheduling appointments and things like that. But it also, unfortunately, further politicizes vaccines because many of the states that are doing this are blue states. And so it now suggests that, well, depending on your political allegiances, vaccines may or may not be for you. And that's just a really awful situation for the country to be in. I'm just really worried about the vulnerability it creates in the United States, and to our earlier conversation about biological attacks. I mean, it looks like, only there's this exquisite vulnerability in parts of the country.
But you also, I mean, you didn't mention, but it also makes it hard for companies because, if they're going to need to predict how many doses to do and what to do. And if you have different recommendations in different places and different vaccines, and it again will make it hard to have the type of responses quickly that we need.
And I'm wondering too, I mean, how these evidence-based recommendations are going to be formulated, because typically the ACIP has access to proprietary data that it summarizes and presents to the when there were people with appropriate expertise on the committee that they could review and then make judgments. I wonder if the companies are going to share these data with the states. It's just, anyway, there's just a lot of open questions. I think it's a necessary step, but I don't want people to get the impression that everything is going to be fine, that it's all figured out, that the states are just going to step in and fill the gap, because I see a lot of gaps that remain. Absolutely. It's been cleared out, but I just want to answer it because I think if we don't answer it, people will get the wrong impression. But there was a question in here about the harms of COVID vaccines. Do you see big harms from the COVID vaccines? And I'd like to get your take on that as a vaccine expert.
Yeah, I think it's a very important question. And I think this gets to why we have to have transparency and openness. I mean, these vaccines have been used now in, multiple billion people. So it's not like we don't have small amounts of data on these vaccines. They have been widely used, and they are safe and they are effective. Some vaccines were more effective than others, and there was a lot of debate about that. And frankly, I would have preferred to have had head-to-head testing of vaccines, which is something that we tend not to do. And it's something, again, a learned lesson we can do to help us understand how they work. But the vaccines have side effects. That's true for all different types of vaccines. Those side effects are much less than the natural infections. So things like myocarditis that occurred, some of the clotting disorders, these are things that occur much more commonly in people who have natural infection. And of course, what we see with COVID is in an unconstrained environment, everybody gets it, but they get it more than once because the strains are changing. And so, and overall, the vaccines were quite successful. But I think the point here is having these transparent systems, having reporting of this, and having discussions about it openly is critical to having the information that people need. That, by the way, is what, when you license a vaccine, you're not asking the question, does it not have any side effects? Because by definition, it'll have some side effects. The question is the risk-benefit ratio appropriate for that vaccine? And that's something, by the way, that always you want to look at, and because sometimes there are rare side effects you see when you go above the clinical trials at the beginning of 20 or 30 or 40 or 50,000 people. And, as I said, we're in the billions now. So we have a pretty good idea of what they're like.
Yeah, and I just wanted to say, because I referenced there have been some attacks leveraged at Gavi and just global vaccine efforts, just to say that evaluation piece is really critical. It's a really critical part of it, which is looking at the science, comparing not just what is seen among people who are vaccinated and the direct effects of the vaccines, but also the impacts of not vaccinating and what the tolls of these diseases are. And I know a lot of people talk about whether there's too many vaccines, just to recognize that people are exposed to a whole lot of pathogens in their lifetime, and you have to compare that. You can't just take the vaccines on their own. But anyway, Seth, I want to really thank you, first of all, for your leadership, but also for your sharing your insights here today, and for your unrelenting commitment to the evidence and to using science to guide the development and implementation of programs that have had extraordinary impact in the lives of people everywhere, but particularly children. As a parent, I'm particularly grateful for that. So thank you really for that and for the robust discussion today. I'd also like to thank our team at the Pandemic Center who helped put this event together: Bentley Holt, Michael Mitchell, Leah Lovegren, Amanda Kogan, Carly Gaska, Aaron Johnson, Andrea Ulig, and Alice Im. To stay up to date on future sessions, you can use the QR code on the screen to access our link tree, and there you can sign up for our webinar mailing list, catch up on past recordings, and explore other resources like our weekly tracking report, which includes updates on topics like measles, flu, and other global outbreaks. A recording of today's session will be available on the events page of our website next week, along with other previous webinars. And please follow us on social media for updates. Feel free to reach out with any questions or suggestions for future seminars, webinars rather. We'd love to hear from you. And we're just coming up on time, so I think we will be adjourned. So be safe, be healthy, and stay engaged all. Thanks for joining.